Ada suara.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi dan selamat datang kami ucapkan kepada Bapak Ibu dalam acara webinar hari ini dengan tema Addressing Implementation Challenges During Pandemic Response, Learning from the Global Polio Eradication Initiative. Bapak Ibu, acara ini merupakan persembahan dari Pusat Kedokteran Tropis Universitas Gajah Mada yang bekerja sama dengan Fakultas Kedokteran Universitas Udayana, John Hopkins University, beserta Bill and Melinda Gates. Eradication. Perkenalkan, saya Rima dan senang sekali hari ini saya bisa hadir di hadapan Bapak Ibu dalam acara webinar sebagai Bapak Ibu yang kami hormati, kami juga ingin menyapa terlebih dahulu kepada yang terhormat Dr. Yodi Mahendradhata, Master of Science, Doctor of Philosophy, Fellow of Royal Society for Public Health, selaku Dekan and Interim FKKMK UGM. Selamat pagi Pak Yodi. Tak lupa kami ingin mengucapkan selamat pagi kepada yang terhormat Profesor Dr. Imade Adirawan, Master of Public Health, Doctor of Philosophy, selaku Wakil Dekan Bidang Akademik dan Informasi Fakultas Kedokteran Universitas Udayana. Tak lupa kami juga ingin mengucapkan selamat pagi kepada Bapak Ibu pembicara dan juga pembahas. Selamat pagi Dr. Hariadi Wibisono, Master of Public Health dari Indonesia Epidemiologi Association.
Selamat pagi.
Selamat pagi Dok, terima kasih. Kami juga ingin mengucapkan selamat pagi kepada Dr. Stephen Jacko dari WHO Country Office of Indonesia. Tak lupa kami juga ingin mengucapkan selamat pagi kepada perwakilan dari Kementerian Kesehatan. Selanjutnya kami juga ingin mengucapkan selamat pagi dan selamat datang dari Indonesia kepada Dr. Olakunle Alonge dari John Hopkins University. Selamat pagi Dok. Selamat pagi juga kami ingin ucapkan kepada Dr. Anna Kalbarczyk dari John Hopkins University. Dan yang terakhir, tak lupa kami juga ingin mengucapkan selamat pagi dan selamat datang kepada Dr. Riris Andono Ahmad, Master of Public Health, Doctor of Philosophy. Pak Doni, selamat pagi.
Selamat pagi Mbak, apa kabar?
Baik, terima kasih banyak Pak Doni dan Bapak Ibu. Kami juga ingin menyapa peserta yang hadir secara luring langsung di Swiss Bell Resort Wat Jimbar, Bali. Terima kasih banyak Bapak Ibu untuk kesediaannya hadir pada acara kami. Baik, Bapak Ibu yang kami hormati, ada sedikit peraturan yang harus kami ingatkan kepada Bapak Ibu. Jadi nanti Bapak Ibu silakan untuk menggunakan Q&A feature dari Zoom masing-masing dengan format nama, underscore instansi, underscore pembicara yang dituju, underscore pertanyaan. Jadi nanti akan ada sesi tanya jawab. Bapak Ibu silakan untuk mengajukan pertanyaannya melalui Q&A feature dengan format nama, underscore instansi, underscore pembicara yang dituju, underscore pertanyaan dari Bapak Ibu. Dan untuk kepentingan e-certificate, mohon Bapak Ibu untuk jangan lupa mengisi attendance form. Dan nanti kami akan tunggu hingga pukul 23.59 waktu Indonesia bagian Barat. Dan e-certificate bisa Bapak Ibu dapatkan maksimal H+14 setelah webinar. Baik, Bapak Ibu, untuk menyambut kedatangan Bapak Ibu secara resmi, mari kita sama-sama dengarkan sambutan dari Profesor Dr. Imade Adirawan, Master of Public Health, Doctor of Philosophy, selaku Wakil Dekan Bidang Akademik dan Informasi Fakultas Kedokteran Universitas Udayana. Kepada Prof. Adi, silakan.
Pertama-tama puji syukur kita panjatkan kehadirat Tuhan Yang Maha Kuasa karena hari ini salah satu kegiatan ya webinar dalam rangka kita mempelajari ya pembelajaran dari polio, pengendalian polio untuk diterapkan di pengendalian pandemi COVID-19. Because we have international guests, I would like to welcome all of you. Thank you for being with us. Thank you for coming today, for taking your time with us, especially Pak Yodi. Terima kasih dari Universitas Gajah Mada bersama tim ya. Kemudian ada Bapak Ibu pembicara hari ini yang dari Kementerian Kesehatan, Dr. Endang, kemudian dari WHO Country Office, Dr. Stephen, and also our colleagues from John Hopkins University. Anna and Olaf, thank you for being with us from the last 2 days. And of course, our participants today, yang sudah hadir secara, maaf ya campur-campur, yang hadir secara offline dan online, terima kasih sudah Bapak Ibu mengikuti workshop dari 2 hari yang lalu dan hari ini nyambung ke webinar. Terima kasih juga kepada semua pihak, semua panitia yang sudah bekerja keras ya. Saya berdiri di sini mewakili Bapak Dekan yang tidak bisa hadir hari ini. Dan sekali lagi mengucapkan selamat, semoga kegiatan webinar hari ini bisa berjalan dengan lancar dan kita bisa mendapatkan banyak informasi. Kita bisa belajar banyak untuk bisa kita terapkan kembali ke ke tempat kerja masing-masing. Saya tahu pesertanya Bapak Ibu ada yang dari praktisi, dari mahasiswa, dari dosen. Kita belajar dari apa yang sudah dilakukan oleh Global Polio Eradication Initiative untuk mengatasi berbagai tantangan, baik dalam tantangan untuk surveillance, vaksinasi, maupun tantangan dalam bagaimana kita mengkomunikasikan risiko, tantangan dalam mengkoordinasikan untuk kesiapan kita menghadapi pandemi-pandemi selanjutnya. Baik, mungkin itu yang bisa saya sampaikan. Sekali lagi Bapak Ibu, selamat mengikuti webinar. We hope that you will enjoy today's event. Thank you very much.
Terima kasih banyak kami ucapkan kepada Prof. Adi. Baik, Bapak Ibu, selanjutnya kita langsung masuk ke acara inti pada kesempatan kali ini yang akan langsung dipimpin oleh Dr. Yodi Mahendradhata, Master of Science, Doctor of Philosophy, Fellow of Royal Society for Public Health, selaku Dekan at Interim Fakultas Kedokteran, Kesehatan Masyarakat, dan Keperawatan Universitas Gajah Mada. Untuk itu langsung saja Bapak Ibu, mari kita sambut Dr. Yodi Mahendradhata, M.Sc, PhD, FRSPH.
Terima kasih, Mbak Rima. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, everyone. To my dear colleagues from John Hopkins University, Kunle, Anna, and also Dr. Stephen Jacko. Allow me to speak in Indonesian. There is an interpretation button below you can use for the English translation. Okay. Baik, Ibu Bapak semua, kabar buruknya COVID masih bersama kita. Angkanya masih cenderung naik akhir-akhir ini di Indonesia. Saya pun ini bicara dari kamar saya sudah di sini sejak seminggu karena sedang isolasi mandiri. Dan kabar buruknya juga kalaupun ini berlalu, kemungkinan besar akan ada pandemi berikutnya, hanya masalah kapan. Karena kita memang hidup di era pandemi, di era krisis. Sehingga memang kita sangat perlu untuk bisa mempersiapkan diri untuk bisa lebih baik dalam mencegah dan merespon pandemi-pandemi ataupun krisis-krisis berikutnya. Nah, kabar baiknya sebenarnya cukup banyak aset-aset pengetahuan yang kita miliki untuk bagaimana mencegah dan merespon sebuah pandemi. Dan salah satunya bisa kita dapatkan dari pembelajaran dari program eradikasi polio yang sudah sangat berhasil dalam melakukan banyak hal yang juga relevan kaitannya dengan pandemi, misalnya terkait dengan surveillance, terkait dengan vaksinasi, koordinasi, dan sebagainya. Nah, sehingga dalam diskusi kita pada pagi hari ini nanti akan kita bagi menjadi beberapa segmen. Segmen pertama, kita akan membicarakan mengenai apa saja sih kendala-kendala utama pada saat kita merespon pandemi ini, terutama dalam konteks surveillance ataupun dalam konteks vaksinasi. Ya. Itu bagian pertama. Kemudian bagian kedua kita akan membahas kalau kita melihat kembali dari program eradikasi polio, pembelajaran apa saja yang bisa kita dapatkan dari situ untuk dapat lebih memperkuat lagi upaya-upaya pencegahan dan respon terhadap pandemi. Dan terakhir nanti akan kita bungkus dengan ke depan what's next, the way forward, jalannya kemana untuk ke depannya. Nah, untuk itu kita akan langsung masuk pada bagian yang segmen pertama. Di sini ada dua expert yang akan kita hadirkan. Yang pertama, saya menyapa pakar kita yang pertama, Dr. Hariadi Wibisono. Dr. Hariadi, bisa mendengar suara kami dengan jelas, Dok?
Mendengar, Pak Jodi, silakan.
Oke, sehat ya, Dok ya?
Alhamdulillah.
Ya, alhamdulillah. Baik, Ibu Bapak, jadi Dr. Hariadi ini kalau kita lihat di CV-nya panjang dan menjadi ketua di banyak posisi. Sekarang menjadi chair dari ini Jaringan Epidemiologi Indonesia dan juga chair dari National Certificate Committee for Polio Eradication. Dan beliau juga chair untuk expert committee untuk leprosy and frambosia elimination. Nah, kita di sini berharap Dr. Hariadi bisa sharing dengan kita pengalaman beliau, refleksi beliau tentang terutama apa saja sih kemarin kendala-kendala utama untuk dapat melakukan surveillance dalam konteks pandemi selama COVID-19 ini. Silakan Dr. Hariadi, waktunya 15 menit.
Baik, terima kasih Dr. Jody. Assalamualaikum warahmatullahi wabarakatuh. Good morning for foreign participant from John Hopkins, and selamat pagi also for Pak Stephen Ceko, WHO Indonesia. I will speak in Bahasa because I'm sure that there will be a translator for you to follow my presentation. Bapak Ibu sekalian, memang topik yang diberikan pada saya pada pagi hari ini sangat menarik, dan izinkan saya berbagi share slide. Apakah sudah bisa kelihatan?
Dalam proses, Dr. Hariadi. Sudah, tinggal di slideshow.
Ya, cuman saya biasanya kalau dengan slideshow malah jadi hilang.
Oh, tidak apa-apa.
Jadi
cukup besar ini, bisa dibaca.
Jadi sesuai dengan judul, Challenge in Implementing Surveillance System in the COVID-19 Pandemic Response, adalah suatu topik yang menarik karena kita akan meninjau kembali seberapa jauh suatu sistem surveillance itu mampu menjawab, menghadapi tantangan yang ada yang seharusnya bisa di-cover oleh sistem surveillance tadi. Saya akan merujuk pada definisi yang sering kita dapat di buku-buku. Ini saya membuat sepanjang redefinisi bahwa surveillance adalah proses analisis yang sistematis berkelanjutan terhadap data yang dikumpulkan dalam bentuk informasi kepada pihak yang memerlukan untuk melakukan tindakan. Artinya adalah surveillance adalah analisis untuk suatu action. Nah, apakah bisa diikuti slide yang bergerak ini, Pak Jody?
Bisa dok. Oke, silakan.
Nah, jadi peran utama sesuai dengan amal dari International Health Regulation ataupun Global Health Security Agenda, peran utama surveillance adalah early detection and immediate corrective action. Tanpa mampu menjawab tantangan mengenai early detection dan immediate corrective action, maka kita harus meninjau kembali apakah sistem itu perlu diperbaiki. Fungsi utamanya adalah deteksi dini, investigasi dan konfirmasi, analisis, interpretasi, dan action. Untuk itu memang membutuhkan faktor pendukung. Nah, kalau kita bisa melihat di sini, maka diseminasi informasi tadi ada dua hal yang sangat penting dan sering terlupakan. Pertama adalah penyampaian secara langsung kepada pembuat kebijakan dan penyampaian pada penanggung jawab program di lapangan untuk suatu respon cepat. Yang sering terjadi adalah berbagai laporan itu langsung dikirim ke atas, tapi lupa justru kepada sender, the priority side yang membutuhkan informasi tadi dalam rangka membuat follow up action ataupun memutus rantai penularan. Jadi pemanfaatan hasil analisis dan interpretasi tadi lebih dipentingkan pada respon cepat, tata laksana kasus, kemudian program pencegahannya. Di samping ada program perencanaan dan lain sebagainya. Namun kalau kita bisa melihat seberapa jauh, saya akan merujuk pada pengalaman dengan surveillance untuk polio. Kita tahu bahwa surveillance untuk polio melalui surveillance AFP adalah surveillance yang sangat lengkap. Kita bisa melihat komponen-komponen yang ada, di mana komponen tadi kita bisa melihat nomor satu adalah bagaimana kita menemukan semua kasus lumpuh layu atau acute flaccid paralysis. Tidak mempersoalkan apakah dia polio atau bukan, tetapi kita berbicara ke hulu setiap kasus kelumpuhan, maka itu harus ditindaklanjuti. Dan untuk itu kualitas dari pekerjaan tadi juga dipantau. Apakah penemuan tadi sesuai dengan yang standar? Apakah berhasil mengumpulkan spesimen di mana kualitasnya adalah 2 spesimen dengan rentang waktu 24 jam. kemudian bagaimana pengiriman spesimen tadi, dan diperiksa di laboratorium dalam jangka waktu yang ditentukan. Variabel-variabel tadi tentunya diikuti dengan pemberian imunisasi. Dua komponen ini selalu datang bersama-sama. Namun untuk komponen surveillance-nya kita akan melihat apakah surveillance tadi mampu menjawab. Untuk surveillance AFP, maka kita harus melihat bahwa sebelum adanya program imunisasi atau vaksinasi, kita memiliki dua komponen dari acute flaccid paralysis, yaitu AFP yang karena polio dan AFP karena non-polio. Dengan adanya pemberian vaksinasi, apakah itu OPV atau IPV, maka mestinya yang hilang ataupun yang tidak ditemukan adalah kelumpuhan yang karena polio. Yang ada atau yang sisa dan harus ditemukan adalah kelumpuhan yang karena non-polio. Dan ini ada perhitungan targetnya yaitu 2/100.000 untuk anak di bawah 15 tahun. Kita sering banyak pihak menganggap dengan adanya eradikasi polio, maka kotak yang biru ini dianggap juga sudah tidak ada. Padahal ini sebagai ukuran kualitas. Disinilah terletak kasus-kasus Guillain-Barré, kasus-kasus mielitis transversa, kasus-kasus kelumpuhan yang lain. Sebaliknya, untuk yang kotak yang warna coklat, yang seharusnya tidak ada, sekarang ini ternyata muncul tantangan baru, yaitu adanya mutan-mutan baru, ataupun vaksin derived poliovirus. Dan ini membutuhkan suatu tindakan yang akurat dan analisis yang tepat. Jadi kalau kita bicara mengenai sistem surveillance-nya itu sendiri, maka kita harus melihat bahwa ada suatu kualitas yang diukur dari suatu proses. Kasus ditemukan dalam waktu 14 hari, tinja yang dikumpulkan sebenarnya 8 gram, kemudian spesimen tinja dimasukkan dalam rantai dingin, dalam spesimen dalam suhunya 2-8 derajat, dikirim ke laboratorium dan harus mencapai laboratorium dalam waktu 3 hari dengan tingkat adekuasi yang telah disepakati. Ini semua harapannya adalah kita mendapatkan semua kasus kelumpuhan di mana kemungkinan adanya wild poliovirus tadi. Kita sangat tergantung. Namun dengan berjalannya waktu, dengan berbagai kebijakan yang ada, toh sampai hari ini kita mendapatkan gambaran yang belum seperti yang diharapkan. Karena di banyak tempat kita sudah mendeklar kita bebas dengan polio liar. Namun pada saat bersamaan di berbagai belahan dunia muncullah vaksin derived poliovirus. Bahkan sekarang di Amerika dan di Inggris ditemukan kasus polio yang ditemukan dari sewage. Artinya apa? Kalau limbah tadi mengandung virus polio, maka menjadi pertanyaan, siapa penyumbang atau yang mencemari lingkungan tadi? Apakah orang yang masih menggunakan OPV yang masuk? Karena kita tahu di negara Amerika ataupun Inggris, mereka menggunakan IPV. Mestinya tidak ada kontaminan pada tinja. Namun ternyata ada. Artinya apa? Ada seseorang yang masih divaksinasi dengan OPV dan ternyata tinjanya mengkontaminasi limbah dan terdeteksi. Bagaimana juga berarti negara tersebut terpaksa berhadapan. Sistem ini akan mendorong kita bagaimana kita menghadapi surveillance tadi untuk berbagai penyakit yang kemungkinan muncul berikutnya. Dalam hal ini kita ambil adalah COVID-19. Kita tahu bahwa COVID-19 tadi ada dua komponen. Kalau untuk surveillance AFP, kuncinya adalah kemampuan menemukan kasus AFP, kemampuan mengambil dan memeriksa spesimen, dan kemampuan follow-up 60 hari. Pada COVID-19, surveillance yang sistem yang diharapkan mampu menemukan kasus, mampu menemukan dan melacak kontak, mampu memeriksa spesimen, dan kemampuan menentukan varian. Poin nomor 2 ini kita masih menghadapi tantangan. Betulkah setiap kasus kita mampu menemukan setidaknya 12 kontak? Dan di banyak daerah di Indonesia ternyata angka itu masih jauh. Artinya kita membutuhkan penguatan upaya surveillance untuk mampu menemukan 12 kasus. Angka 12 ini adalah hasil dari suatu studi bahwa di setiap rumah minimal ada 5 orang, berarti 5 itu menjadi kontak, kemudian teman sekantor, dan lain sebagainya. Sehingga 12 itu mestinya adalah angka yang sangat reasonable. Yang kedua, pemeriksaan spesimen sejauh ini tidak ada masalah. Namun, betulkah jarak pengambilan spesimen dan hasilnya tadi bisa keluar dalam waktu kurang dari 24 jam? Di banyak tempat diambil hari Senin, ternyata keluar hasilnya baru hari Jumat. Kita bisa membayangkan antara Senin dan Jumat sudah terjadi penularan, apapun hasilnya. Apalagi kalau hasil spesimen tadi positif. Dan kita tahu dengan peduli lindungi yang ada, di mana setiap hasil positif memberikan otomatis peduli lindungi kita berwarna hitam. Tapi kalau peduli lindungi tadi berubah warna hitam berdasarkan hasil yang dikeluarkan lab, yang ternyata sebagai contoh tadi keluarnya pada hari Jumat, maka pertanyaannya adalah dari Senin ke Jumat yang bersangkutan kemungkinan sudah menularkan kepada orang lain. Yang keempat adalah yang tidak kalah pentingnya adalah kemampuan menentukan varian. Kita bicara Omicron, kita bicara B2, kita bicara Delta, dan lain sebagainya. Untuk itu memang penting sekali World Genomic Sequencing itu menjadi suatu tuntutan zaman. Pertanyaannya, apakah kita sekarang sudah siap untuk mampu menyediakan data dari genomic sequence tadi secara akurat, tepat waktu, tepat tempat. Jadi kalau kita kembali pada pengalaman yang kita dapat membandingkan antara polio dan COVID, ada beberapa titik persamaan. Pertama adalah penemuan kasus. Kotak yang di atasnya adalah menggambarkan untuk AFP, kotak yang warna kuning untuk COVID. Penemuan kasus, gejala klinis, penemuan aktif pasif, mencari kasus polio, dan follow-up. Sebaliknya untuk COVID, penemuan kasus berdasarkan gejala klinis, penemuan aktif secara pasif, dan penemuan kontak. Pengambilan spesimen, 2 spesimen tinja untuk polio, rentang waktu 24 jam sebanyak 8 gram dengan label yang benar. Untuk COVID, kita membutuhkan ketepatan waktu dan kecepatan hasil. Dan ternyata di banyak tempat 3 variabel ini belum menjawab seperti yang diharapkan. Pengiriman sampel tinja untuk AFP, maka dengan label yang benar, tabung yang kuat, kemudian hasil yang akurat dalam waktu tertentu. Untuk ini, untuk COVID, kita membutuhkan akurasi dari pemeriksaan sampel. Betulkah pemeriksaan yang dilakukan tadi akurat? Di banyak tempat, pada waktu melakukan swab di nasofaring, ternyata ataupun tidak cukup dalam, sehingga walaupun sudah diambil swab, walaupun ada gejala klinis, gejalanya bisa false negatif. Dan ini perlu mendapatkan perhatian keterampilan di dalam pengambilan spesimen. Hal ini akan mempengaruhi kita. Dan inilah gambaran terakhir bahwa sampai hari ini, COVID walaupun sudah menurun, saya lebih mengatakan war is not over yet. Pertempuran belum berakhir. Di satu sisi, banyak masyarakat dengan adanya pelonggaran menganggap COVID sudah lewat. Protokol kesehatan sudah abai. Vaksinasi cakupannya belum cukup tinggi. Bahkan sekarang vaksinasi dosis 2 pun ternyata belum seperti yang diharapkan. Apalagi kita sudah membutuhkan booster. Apalagi diperlukan booster kedua. Di saat harian kita masih melihat fluktuasi kasus-kasus COVID. Walaupun kita sadar bahwa kasus yang muncul sekarang ini tidak membutuhkan rumah sakit. Jadi pemakaian tempat tidur rumah sakit masih sangat rendah. Kemudian kasus-kasus rumah sakit juga bahkan tidak membutuhkan. Artinya kasusnya cukup rendah. Namun yang perlu difahami adalah persepsi masyarakat bahwa gejala yang munculnya gejala flu biasa, ini justru yang berbahaya. Flu biasa, orang tidak berpikir menularkan. Tapi flu biasa, gejala flu yang ada pada COVID, tanpa isolasi mandiri, orang tadi akan menularkan pada orang lain. Sehingga rantai penularan masih akan terus-menerus. Dan ini tergambar dari grafik-grafik yang muncul saat ini, bahwa kita masih ada memiliki penambahan kasus setiap harinya, fluktuatif di masing-masing daerah. Saya kira dengan demikian kita harus belajar di titik mana surveillance untuk penyakit ini harus kita perkuat. Deteksi di tingkat frontline itu menjadi kuncinya. Kemampuan petugas untuk mengetahui gejala klinis, kemampuan petugas untuk mengambil sampel, dan kemampuan komponen pendukungnya itu laboratorium untuk segera memberikan jawaban. Tanpa itu, surveillance tadi tidak mampu menjawab early detection dan rapid response. Mudah-mudahan penyajian singkat ini bisa menjawab keinginan kita. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih banyak Pak Hariadi atas sharingnya, dan tadi pesan utamanya kuncinya di detection di front line tadi ya Pak Hariadi ya. Tanpa itu tujuan utamanya tadi early detection, immediate corrective action tidak akan bisa tercapai. Dan ya tadi beberapa hal sangat relevan bagi saya. Peduli lindungi saya masih hitam Pak Hariadi. Dan itu juga kemarin ada delay beberapa hari juga, jadi memang agak geser antara tanggal harusnya isoman dengan tanggal yang ada di Peduli Lindungi. Baik, terima kasih Pak Hariadi. Kita akan beralih dulu ke narasumber yang berikutnya. Untuk para peserta, silakan Anda bisa mulai menulis di Q&A ya. Nanti silakan bisa bahasa Indonesia, bisa bahasa Inggris, nanti akan ada translator. Jadi silakan Anda bisa mulai tulis di Q&A, nanti akan dijawab oleh narasumber kita pada saat sesi Q&A. Okay, we now move to our second speaker. So we have the honor to have here with us Dr. Stephen Chako. He's the team leader for immunization of the WHO country office here in Indonesia. And previously he was with WHO in Bangladesh as a medical officer, immunization and vaccine development. And after that, he was with WHO also in Myanmar as team leader immunizations. And now he's here with us in Indonesia. And he will share with us the challenge of implementing vaccination during the COVID-19 pandemic to protect the community. Dr. Chako, can you hear us audibly?
Yes, Dr. Yodi. Can you hear me? Can you confirm whether you are? Okay.
Very clear, very clear. So yes, we have 15 minutes for you to present, Dr. Chako. Yes. The time is yours.
Okay. Yeah. Can you please confirm whether you are seeing my slide in?
Yes.
Okay.
It's clear. Yeah.
So thank you, respected colleagues. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, Bapak Ibu. Without further discussion, maybe I will just go into my presentation so that the 15 minutes, I can complete my slides in 15 minutes. Dr. Hariadi had just eloquently described the issues related to surveillance and also for all participants, I believe that can appreciate the overall challenges. When we talk about the immunization, it is also another very important for polio eradication. As you know, that the core pillars are routine, immunization, improvement, surveillance, then supplementary immunization, etc. So one of the main strategies for Dr. Hariadi had mentioned. Now let's discuss about immunization challenges in Indonesia during COVID pandemic. And when we talk about any missed children, sometimes we need to combine as a whole. I mean, it can be to DPT, Penda, Penda, polio, measles, rubella, and other vaccines. So without further intro, I will just go into the first slide. And here, this latest, the WUNIC data, the WHO UNICEF Global Immunization data published in July. And where, as you can see, that Indonesia is one among the top 10 countries which is having a high number of zero dose. And also, when you talk about measles and rubella vaccine, that's also Indonesia is reflected there as a highly populated country, such a big country with its own geographical challenges. Among the big countries, India, Nigeria, and other populated countries are also reflected here. Now, again, here it is highlighting in terms of the numbers, more than 1.1 million children are missing any kind of vaccination after during this 2019 to 21 period. Now, if you talk particularly in the area of immunization in Indonesia, you can see that 4.4 million annual cohort, it's a big cohort. And then during COVID pandemic, more than 1 children miss immunization. And another issue is inequitable utilization, immunization surveys and coverage. And so it can vary from the data. It can say that some areas are having coverage of 42 and some maybe in Java, provinces in Java may have higher coverage. But if you come look at the slide, the 2019 DPT-3 coverage, and compare it with the 2021, you will see the significant drop between these periods. Yeah, I mean that is quite a big number. And if you compare the table also, you will see that the provinces which were performing better in 2019 had also slipped over the period of this pandemic. Now that has reflected in the global measles rubella data that, as you all understand, measles rubella cases, it's an indication of health systems or immunization systems. But Indonesia is also showing high number of, or the measles incidence rate in Indonesia has increased. And in this slide, it is clearly showing that if you compare it with 2021 and 2022, that itself will show the numbers are clearly visible here. In 2021, the 132 measles cases in 71 districts, which has changed to 1,164 confirmed measles cases, and the spread of district is also has increased, and it is now reaching more than 26 provinces. And when we talk about measles rubella, the same picture can be inferred for other immunization areas as well, including for bivalent OPV as well as IPV. Here, let me just reiterate some of the particular challenges so that we all understand where what interventions are possible. Now, during the COVID, the temporary closure of the health post, as you know that Indonesia has such an extensive network of posyandu and puskesmas as well as posyandu, which is more than 200,000 posyandu. So if a closure of such integrated health post can significantly cause problem to the immunization outreach. Now, coming into the second point, health workers' competing priorities. You can imagine that during the pandemic, all the health system, including very high income countries as well as upper middle income country like Indonesia, also had overstretched its health systems, and the same health workers were addressing COVID-related vaccination as well as COVID-related responses. So that has also brought in issues for routine immunization coverage as well. Now, when you talk about the resources available at the posyandu and puskesmas level, we have observed that it is not equitably distributed throughout the country. Some of the areas are having better resources, so that may have affected the routine immunization. Also, if you come to the fourth point, parents, it is obvious that during the COVID pandemic, many of them were hesitant to visit any of the health facilities, and that also had affected the overall routine immunization decline. And then vaccine hesitancy is also though it is not the biggest issue or the highest in terms of priority, but still that is an issue particularly in some provinces of Indonesia. And then temporary stock out of vaccines and logistics also had caused routine immunization decline. And now the government had tried, government of Indonesia, in multiple ways to improve the immunization. Similar efforts are happening elsewhere in the region. So here in Indonesia, increased government commitment at subnational level. There have been several inter-sectoral coordination meetings and to revitalize the immunization. And then to revitalize the integrated health force at community level, the efforts are being made. Now, increase health workforce capacity, I mean, that in terms of reorientation for the new cadres as well as quality improving activities are being done. Now, in addition to this, though it is not directly related, the fourth point is the new vaccines are planned to be introduced in Indonesia that can also increase demand overall and improve the immunization. Because as you can understand that any new vaccine introduction is before the vaccine introduction, several activities like training, cold chain capacity improvement, and other activities are done. So that will definitely reflect in the coverage. So that is in Indonesia, the expansion of HPV, expansion of PCV, and introduction of Rota, and the addition of IPV2 is planned in 2022. So all these activities will definitely bring in additional coverage, or that is what we as partners are expecting. And then the monitoring and evaluation by multi-sectoral partners, that is also encouraged. And now in Indonesia, we can see that the use of or digitalization of this home-based records is happening. And even the currently ongoing vaccination drive, which is called BIAN here, is also the digital database or digital record keeping is used. And overall, in the coming years, the country is planning to completely transform the home-based record to the digital database so that the default tracking and monitoring and all is better conducted in Indonesia. Now, apologies for this very crowded slide, but the summary here is that government is taking some action to close the immunity gap. That is, there is an ongoing immunization drive, which is called the BIAN, the National Vaccination Drive, which includes the MR vaccines, the Penta catch-up, IPV catch-up, and BOPV catch-up. So if you can see the red highlighted numbers, that the figures are showing that for MR, the target is more than 36 million children ranging from 9 months to up to 15 years in certain provinces. And for DPT, more than 1.5 million missed children are targeted to be covered under this BIAN. And then IPV, quite a significant number. And then BOPV, also 2.4 million are expected to be covered. And this the vaccination drive is ongoing at the moment. It was started from 18th of May in 27 provinces. And that was the phase 1 of the campaign. And the phase 2 is now ongoing in the remaining Java province, 7 provinces. And quite a significant drive, and most of the support or the operational support as well as vaccine are mostly done by the government. There is high-level commitment. As we speak, there are more than 19 million children have been vaccinated since May 18th. So that will continue till most likely this month and next month, and hopefully a very high coverage can be achieved through this drive. So in summary, as you all understand, colleagues, immunization saves life, and currently it is preventing millions of deaths every year. And recovering routine immunization and VPD surveillance is very crucial. Pak Hariadi had mentioned about the surveillance part of it, early detection of any diseases, including the circulating vaccine-derived polio, and the importance of environmental surveillance and AFP surveillance you had mentioned. And the routine immunization, as you can see, that has fallen, and which leads to increased number of high-risk population. And the vaccination campaign should be conducted. That was the recommendation from the CRO TAG, as well as from the Regional Verification Commission. And in Indonesia, the vaccination drive is the BIAN, which is ongoing now. Then overall, it is encouraged to strengthen the in-country capacity to vaccine preventable disease outbreak response. So I stop here, and I will be happy to take any questions if you have. Thank you very much. Over to you, Chair. Thank you.
Thank you very much, Dr. Chaco, for eloquently laying out what were the key challenges of vaccination throughout the pandemic. And you highlight at least 6 big ones, but there has been also efforts to remediate that. That's something that we will also discuss. In terms of the Q&A, we will address that during the Q&A session, but please do have a look at the Q&A feed box. There might already be some questions there, but we'll go through them later on the Q&A session. So please stand by, Dr. Chaco, for the Q&A sessions, okay? Ibu Bapak yang kami hormati, untuk narasumber yang ketiga dari Kementerian Kesehatan, sayangnya ini last minute kita mendapat informasi bahwa berhalangan untuk hadir, sehingga kita akan langsung berlanjut pada sesi pembahasan. Ya. Jadi pada sesi pembahasan ini kita akan mendengarkan pembahasan dari sisi polio, dari eradikasi polio. Bersama kita 2 expert kita dari John Hopkins University, Dr. Olakunle Alonge dan Dr. Anna Kalbarczyk. Keduanya adalah lead dari Stripe Project. Ini adalah proyek yang didanai oleh Bill Melinda Gates Foundation untuk dapat mengkompilasi berbagai pembelajaran yang bisa kita dapatkan di program polio supaya terdokumentasi dengan baik, karena banyak sekali good practices, best practices dari situ, dan juga termasuk dalam hal itu apa saja yang bisa kita manfaatkan untuk penguatan-penguatan program-program lain, termasuk dalam hal ini bisa juga kita aplikasikan untuk kepentingan upaya-upaya pencegahan maupun untuk respon pandemi. Kunle, can you hear me clearly? Kunle, can you hear me?
Yes, Yodi, I can.
Okay.
Can you hear me?
Good. Yes, I can hear you clearly.
Great.
So, Kunle, so we are now in the discussion section in which we would like to discuss. We hear already from Dr. Hariadi and Dr. Stephen Chaco what were the challenges in terms of surveillance and vaccination throughout the pandemic. And so here we would like to see whether there are actually some lessons we can draw from the global polio eradications in terms of overcoming those and other challenges throughout the pandemic. So for that, the time is yours, Kunle, for the next 15 minutes.
Yeah, thanks, Yodi, and thanks to colleagues that have presented before me. And again, it's really a pleasure to be with all of you. And over the next 15 minutes, I'm really going to be reflecting on the lessons learned from the Polio Eradication Initiative and how those lessons could be applied for health emergencies, pandemic preparedness, and response and resilience. Given all that has been said with regards to COVID, with regards to routine immunization program, the commonality is really around systems being ready, systems being prepared to be able to address emergencies, to sustain routine health services during those emergencies, and to recover in a way that the systems are able to provide for the services that are needed in the community. So there are a lot of lessons that the polio program do offer us. The Global Polio Eradication Initiative is the largest initiative of its kind, and it has been on for so many years, and it's global in scale, with its influence at different levels, from the global to the national to the subnational levels. And therefore, it offers us a lot of opportunities to learn on how we all can come together as a global community to address public health emergencies that threatens lives and livelihood in our global community. And to guide me in describing that, some of those lessons, I thought we should start from the latest framework from the WHO on what is needed for health emergency preparedness, response, and resilience, which encompasses polio, it encompasses COVID response, it encompasses other public health emergency threats. And this again issues from the work that was done here some months ago during the G20, and several other recommendations that has been put forward on the way forward for addressing public health emergencies. So there are three pillars, of course: governance, leadership, systems, and the financing. So I'm just focusing on the systems, which is really where the polio program really do have a lot of lessons to share. There are 5 critical subsystems that are needed in order for every system to be ready for preventing, responding, recovery, control of infectious diseases. One is collaborative surveillance, which is really not just about surveilling for diseases, but also being able to predict vulnerabilities of communities, and linked to that, being able to use resources in a way as to guide treatment, to guide case finding, and so on. And of course, there is community protection, which really embodies community resilience in terms of building social capital and through information, through building trust, and responding to context-based challenges, some of which we've listened to earlier on from the earlier presenters, talking about some of the challenges with routine immunization, some of the challenges with surveillance. So solutions for some of these challenges has to be community-based, and therefore that's another pillar. And then, of course, sustaining care, routine care is in the face of a pandemic, and that really talks about the resilience of the system as well, and layered upon that, being able to provide emergency care as needed. And of course, access to countermeasures, equity, issues around equity in terms of being able to access vaccines, access resources, and so on. And then coordinating all of these subsystems for emergency, and also for routine primary health care, for advancing universal coverage of health and health promotion, and so on. So this framework, the goal is really not to discuss this framework, but my goal is really to use this as an organizing frame to show to you that the Global Polio Eradication Initiative do offers lessons in each of these subsystems. So be it, how do we do surveillance effectively, addressing some of the challenges that has been described before, or how do we vaccinate program, how do we run vaccination programs in a way that it builds systems, in a way that it addresses critical needs, critical bottlenecks within the system, or how do we even address issues around other issues that may be pertinent even for a response emergency. So the polio program really do offers us lessons and critical way forward in thinking about this. And to highlight, while these lessons there are very many, what I've done is just to synthesize just 3. So that it's easy to digest, and if there's anything that I would like you to take away today, I want you to take away these 3 lessons. The first is really around vaccination. Vaccination, as Dr. Stephen Chacko presented earlier on, it's really very critical for the critical component of the essential public health functions. And it's even more important in public health emergencies where we have infectious diseases like COVID and so on. And the polio program provides an important lesson around vaccination. And one of these lessons is that integrated campaigns and social mobilization strategies are critical for supporting vaccination programs. So what do we mean by this? For pandemics, typically, there is a need for us to vaccinate a large population within a short period of time. And oftentimes we rely on campaigns to be able to do this, like we did for COVID, and as we would likely do for other emergencies. And the polio program had actually shown to us that in running those campaigns, it's really important for us not just to be critical or focused on the goal, on the vaccination goal that we're trying to address, but also to be responsive to the needs of the local community that we are working in. And that's really the premise for integrated campaigns. That is to say that when we think about vaccination, be it for any kind of diseases, we should be thinking about co-delivery. And it's one thing that we found out in the polio program that has really contributed to the success of the polio program. That is to say, co-delivery of interventions. You are vaccinating, yes, polio, but you are taking along other vaccines that are important. You are taking along other things that the community needs that are important. And you're not just only addressing infectious diseases, but you're also using those platforms to address the structural and the social determinants of health. So like we see in some communities, in Africa, in Nigeria, for instance, where issues around providing water resources, issues around providing livelihood, were actually tagged along with vaccination program, and which was critical for addressing some of the challenges to vaccination. And similarly, we should also be strengthening routine health systems, even as we vaccinate. So indeed, we design our campaigns in a way as not to distort the health system, but to strengthen the health system. Lessons from the polio program do suggest to us that paying attention to health workers' motivation, paying attention to communities, and involving communities in design of vaccination program is really very critical. And of course, there is social mobilization. We cannot address any public health threat without mobilizing the community. Problems emerges from the community, solutions must always come from the community. Irrespective of how sophisticated our global programs are, the community needs to have a say in shaping a solution. And therefore, it's important to engage, as we learned in the polio program, community engagement, speaking with gatekeepers, speaking with opinion leaders. And as we even implement our program, being sensitive to cultures, using women as social mobilizers, using women as vaccinators. So some of the critical lessons that we think have been demonstrated in the polio program for any vaccination program, which can be extended to COVID and to other programs. I will move on to the second point that I would like you to take away, related to the issue around surveillance. Dr. Hariadi really talked about some of the challenges in terms of being able to identify cases within 24 hours, being able to transfer specimens in a timely period. And honestly, the solution to this, again, it goes back to the community. Indeed, yes, we could have very elaborate global, regional and national surveillance programs linked to laboratory services and so on. But the key to unlocking the surveillance program really lies in the community, particularly if we are trying to address pandemic or we are trying to address disease of epidemic proportion, because there are people that are excluded from the health system quite naturally. And we really need to reach these people in order to be able to surveil diseases and find cases more effectively. And that's really where community-based surveillance plays a key role. It's really important to have, polio shows to us that having community volunteers, people who are residents, who are domiciled in local communities, participating in acute paralysis, case finding, for instance, were critical. And using technology to augment the role of these community volunteers or these networks of community surveillance officers were also critical. And over time, the network that have been created by the polio program has actually been leveraged for other kind of diseases. Like we've leveraged it for COVID, we leveraged it for Ebola in a number of African countries, and we're leveraging it for strengthening routine immunization in many places. And then, of course, there are also their practices, their best practices in terms of how to organize global, national, and subnational surveillance network, which again, the polio program do provide some important lessons in terms of timely transfer analysis of data and using data for decision making. It's something that we learned from the polio program. Adding capacities, laboratory capacities that are linked to epidemiological data to facilitate decision making. It's another important lesson. It's another important best practice that we've seen from the polio program. For instance, the polio program has provided great many assets, including over 150 laboratories, global reference laboratories, regional reference laboratories, national laboratories, which are being repurposed for other diseases. And not just only these laboratories, but there are guidelines and standard operating procedures that are relevant, even from the polio program. But again, I would like to leave you with this, that community is really key. And being able to network within community, being able to harness resources within community, not just only for vaccination, also for surveillance. It helps in two ways. It helps not to only foster the goal of any eradication program or any pandemic response, but it also helps to build community resilience, because information that are shared really builds community trust, it builds social capital within the community, and it helps to build community involvement, which are really critical for any pandemic response and health emergencies. And then finally, coordination, which is really a very critical challenge that we have. Again, a very important lesson from the polio program is that we need to be thinking about interagency implementation teams. We need to be thinking about public health emergency operation centers, which are critical tools for coordinating response in any emergency. So not just even for emergency, even for routine care, you need teams to be, you need agents from different agencies to be working together in order to effectively manage information, manage resources to address and to respond to problem as they occur. So there is a need to link surveillance, vaccination program, and data that are coming from all of those domains to the teams, to the centers to make quick decisions. And the polio program provides a very useful lesson in that for a long time, the global program, the GPI program was stalled because there were bottlenecks in certain countries, Nigeria included, Afghanistan, Pakistan, and so on. And one of the important strategies that were used is really to bring people who are working within countries for different agencies together, people working in epidemiology, people working in programs, people working in advocacy, bringing everybody together into the same room and providing information and data, sharing that together and using that to make decisions together and then following up with each other in implementing those decisions. And that's the whole premise of the emergency operation centers, which have been critical for polio, and it has been found to be critical for other kinds of emergencies, including Ebola, and which has also been activated even for COVID. And there's a need for us to sustain some of these strategies. So for us to not just think about them as emergency operation centers, but to see them as a mainstay of our health systems in a way that they help us to strengthen the system, while at the same time they build resilience within the system so that we can respond quickly. So again, there are many lessons that the polio program do offers us, but I really didn't want to overload you with all of this lesson. There are people who have written a lot about this information, but I just wanted to leave those three information. One is the fact that campaigns and working in community social mobilization is really critical for any vaccination programs, particularly vaccination programs that are responding to pandemic. Two, again, community-based surveillance or working within communities is key for unlocking even global surveillance program. And both of these things really helps to build community resilience, which actually helps in strengthening within health system and also responding to health emergency. And then of course, you need capacity, and capacity are people, capacity are teams, capacity are centers that are working together to administer resources, administer information, and purpose it, target it in the best way possible for any program, including routine immunization, emergency response, and COVID. So thank you again. I will stop here. I know that we are still going to have a lot of opportunity to discuss and to exchange ideas. But I just want to say that some of the things that I'm talking about now, it's a synthesis of many work that involves many people. And there's a whole catch of information and products that have been provided under the project's the START consortium, which we call the Synthesis and Translation of Research and Innovation from Polio Eradication. So we have papers, we have case studies, we have courses, and so on that have been prepared describing some of these critical lessons and demonstrating how some of these lessons could be applied to COVID, to routine immunization, to other kinds of public health issues. So thank you so much. It's really been nice to have this opportunity to speak with all of you.
Thank you, Kunle, for distilling the top 3 lessons. Yeah? So that we're not overwhelmed with all of the lessons, but the top 3 lessons, which is important for us to consider here. So you highlighted the importance of those campaigns to support vaccinations, also to work with the community for surveillance, but also for resilience, and also the critical role of coordinations. Now, we also have Anna here. Does Anna would like to add anything, Anna, or do we go to discussions?
Oh, thank you, Dr. Yodi. No, I'm just here to support Kunle, so nothing to add for me today.
Okay, thank you very much, Anna.
Thank you.
Oke, baik, Ibu Bapak. Jadi kita sudah mendengarkan dari 3 narasumber kita. Tadi Dr. Hariadi sudah memberikan gambaran bagaimana tantangan surveillance di masa pandemi dan persamaan-persamaan antara surveillance untuk polio dan juga untuk pandemi COVID ya. Terus kemudian Dr. Stephen Chako juga sudah memberikan gambaran mengenai berbagai kendala vaksinasi di masa pandemi. Ada 6 tantangan besar dan berbagai hal sudah diupayakan untuk bisa memperbaikinya. Dan yang terakhir baru saja Dr. Olakunle Alonge baru saja memberikan gambaran mengenai 3 pembelajaran utama dari polio yang bisa kita pertimbangkan untuk memperbaiki upaya-upaya kita dalam pencegahan dan juga untuk respon terhadap pandemi ke depan. Nah, sekarang kita masuk pada sesi tanya-jawab. Kita punya waktu sekitar 25 menit untuk sesi tanya-jawab ini. Dan ada 2 cara Anda bisa mengajukan pertanyaan di Q&A box, atau Anda juga boleh raise hand. Ya. So for the Q&A, there are 2 ways. You can also look at the Q&A feature, and there are some questions there which we will take up. But the audience can also raise hands if they wish to speak directly and ask questions. So I'm just going to check because there is 1 raised hand. Ada 1 yang raise hand di sini, Ibu Trifna Irna. Apakah ada pertanyaan yang ingin diajukan secara langsung? Bisa di-unmute, Ibu Trifna, kalau memang ingin mengajukan secara langsung. Oke, belum ya. Oke, kalau belum, kita akan masuk pada yang sudah ada di Q&A. So we have several in the Q&A. There are some for Dr. Chako, there are some for Dr. Alonge, there were also some for Dr. Hariadi. For the one for Dr. Hariadi sudah dijawab ya Dr. Hariadi tadi ya, pertanyaan mengenai lab polio yang tersertifikasi. Ya. Ada tambahan Dr. Hariadi terkait pertanyaan tadi terkait lab polio?
Ya, sedikit tambahan bahwa dengan adanya perkembangan COVID-19 yang begitu masif, barangkali beberapa lab tadi, terutama yang di Badan Litbang dan di Surabaya, barangkali overloaded dengan pemeriksaan-pemeriksaan terkait COVID. Artinya dari segi, tapi tetap officially 3 lab itu yang accredited dari WHO untuk polio specimen examination. Gitu Pak Yodi.
Okay, terima kasih Dr. Hariadi. And then for Dr. Chako, there are a couple of questions. So the question on the Beyond program, both IPV and BOPV are presented in the list. And why does the Indonesian government still use BOPV and not replace them with IPV entirely? Since there is some evidence that BOPV might cause vaccine-induced infection. And the other one is in Indonesian, again related to Bian, asking whether there are already some studies, recent studies about the effectiveness of the vaccine which are given to the children, which are continued with the vaccines for measles and rubella during the Bian. And if there are, can you point out the references so they can use that to communicate, to educate the parents? Dr. Chaka, would you like to respond to these two questions?
Yeah, thank you, Dr. Yodi. Also, thank you for the previous presenters, Dr. Olakunle. And now let me answer the question directly. The first one is about use of IPV. And BOPV. Why is in Indonesia still BOPV use considering the slight risk of vaccine-derived polio and vaccine-associated polio? Yeah. So let me put it this way. I mean, there are pros and cons of using IPV and OPV, and people who are familiar with the polio eradication program will understand that oral polio vaccine, the trivalent OPV as well as bivalent and monovalent, it has a huge advantage over using IPV because of the ease of administration, the operational challenges, the cost, and also the gut immunity, especially for polio, because it is a live vaccine, which is actually helping given in a mass campaign mode. It can also even create the passive immunity as well. So these are some complex immunology related issues, but operationally I would say the chances of vaccine derived polio or vaccine associated polio is 1 in several million doses administered. So it is an extremely rare possibility, but it still exists. That is why certain countries are using only IPV. Like developed countries already moved on with the IPV only regime. But you can imagine the cost implication for a country to rapidly shift from OPV to IPV. That is quite significant. That is why considering the risk and risk-benefit balance, Indonesia is gradually shifting to the IPV regime. We cannot abruptly shift from OPV to IPV, and maybe Hariadi can also explain it because he is also an expert in the area of polio. But I would say that the risk of any vaccine-derived polio or vaccine-associated paralysis is way low than the benefit of getting children vaccinated. So it is strongly recommended to use and there is a gradual shift to IPV is recommended. Now, the second question about MR, co-administration of MR and COVID. What we know that from the global evidence, the available recommendation from WHO as well as CDC, it is okay to get, or it is safe to give COVID vaccine along with this other vaccination. And there are no contraindications as such. Initially, there was a recommended gap of 2 weeks up to 4 weeks between the COVID and other vaccination. But now CDC has removed it. Maybe colleagues from CDC, if they are listening, they can also confirm that they have removed any contraindication of co-administration of COVID along with other vaccine. And we will try to find some links from WHO so that as colleagues requested, Dr. Yodi. So I think I stop here if my questions are over. Over to you, okay. Dr. Yodi. If other colleagues may add, please.
Yes, thank you, Dr. Chako. Dr. Hariadi mungkin bisa menambahkan yang IPV, OPV tadi, dok.
Ya, terima kasih Pak Jody. I would like to add some more important issue, Pak Stephen, related with the use of OPV and IPV. Particularly, there's some still wrong perception that VDPV caused by the use of OPV. Yang ingin saya tekankan di sini, VDPV itu bukan karena vaksin, tetapi karena cakupan vaksinasi yang rendah yang berjalan bertahun-tahun. Sehingga menyebabkan vaksin yang dipakai itu setelah divaksinasi dimasukkan kepada seseorang anak, maka pada waktu anak tadi melakukan dalam tinjanya, maka terjadi suatu proses mutasi dari satu anak ke anak berikutnya, ke anak berikutnya, ke anak berikutnya yang umumnya belum divaksinasi. Maka vaksin yang berasal dari virus yang berasal dari vaksin tadi akan mengalami mutasi. Dan mutasi itu akan berkembang jadi virus yang berbahaya. Jadi perubahan terjadinya virus vaksin menjadi virus VDPV tadi bukan karena vaksinnya, tetapi karena kondisi lingkungan, dalam hal ini adalah low coverage vaccination. Kuncinya adalah harus kita mencapai cakupan yang tinggi. Tanpa itu risiko terjadinya mutasi. Jadi mutasi karena low coverage yang kronik bertahun-tahun. Terima kasih.
Terima kasih, Dr. Hariadi. Dr. Hariadi, maaf, ada pertanyaan tambahan yang di bawah itu terkait program peningkatan skill petugas untuk penemuan kasus.
Oh, ya. Betul, ini saya justru ingin menambahkan. Apa perbedaan antara COVID-19 dan polio? Setiap kelumpuhan, apapun sebabnya, itu menjadi suatu hal yang berita buruk untuk keluarga. Sehingga keluarga dengan sukarela dia akan mencari upaya. Artinya kasus kelumpuhan yang pada suatu keluarga tidak akan disimpan. Dia akan mengatakan kepada tetangganya, anak saya lumpuh. Sehingga lebih memudahkan untuk petugas menemukan. Bahkan di Papua, di daerah yang sangat remote, seorang pendeta dengan mudah, oh di rumah sana itu ada keluarganya dari kampung lain yang di seberang gunung yang datang untuk berobat karena anaknya lumpuh. Artinya kelumpuhan lebih mudah ditemukan karena tidak ada tantangan, tidak ada penolakan dari keluarga. Beda dengan COVID. COVID-19, khususnya orang yang tidak bergejala ataupun kontak, maka terjadi stigma. Dan ini yang menjadi tantangan kita. Seorang kontak, kemungkinan untuk raise hand, I'm contacted person, itu sangat kecil karena dia, kalau dia kontak, dia akan dibatasi kegiatannya, penghasilannya berkurang, dan lain sebagainya. Dan ini menjadi tantangan buat petugas menemukan kasus kontak tadi. Jadi partisipasi ataupun kolaborasi dari masyarakat yang disampaikan Dr. Alonge tadi agak berbeda. Untuk AFP lebih mudah, tapi untuk COVID ada suatu stigma yang harus dibongkar, yang harus diatasi dulu menjadi suatu empati. Nah, kondisi empati inilah yang harus kita bangun untuk menghindari tanggapan-tanggapan negatif dari para penderita COVID yang umumnya bergejala ringan ataupun tidak bergejala. Terima kasih.
Terima kasih, Dr. Hariadi. Kunle, there are specific questions addressed to you on the Q&A, but you're also free if you want to add to the other question which has been raised regarding the OPV, IPV, if you feel like you want to add anything. So Kunle, time is yours.
Yeah, thanks a lot, and thanks to Dr. Stephen and Dr. Hariadi. I quite agree with what has been said already on the issue between OPV and IPV. And I should also add that OPV offers mucosal immunity. That is to say that it prevents infection where through the parts of the body that most infection coming through. So so it has an added benefit of being useful in endemic areas for rapidly scaling up our vaccination program. And like Dr. Hariadi did mention, the problem with vaccine-derived poliovirus is really a problem of low coverages. Most of the places where that has come up, even in the US, we recently had the case in the US. It's always associated with low immunization coverage, and also in some communities, it's associated with some of the low poor conditions, poor living conditions in those areas. So again, the polio vaccine is safe. The OPV vaccine is safe. The IPV vaccine is safe. And to the question around the case finding, and I think Dr. Hariadi really did stress that point, and it's really alluded to the point I was making around community. Really, yes, there are differences, but the mechanisms are similar. So for instance, you would see that both for polio and for COVID, the way the community interacts with cases, really, it's important in how you find those cases. So if, for instance, if there's a lot of stigma in the community, you are not going to find those cases. People are not going to tell you that they have the problem. And that's really where the issue of community-based surveillance, social mobilizers within communities, that's really where they play a very critical role in risk communication, like we found in COVID, in educating the community. You know, people listen to their community members. They're able to open up to them in terms of what their concerns might be. And therefore, some of the solutions that are worked in the polio program has really leveraged these community-based interventions. And to the question around wisdom, there is a question around how local wisdom is being incorporated in global programs. And again, I cannot overstress this, that the success of the polio program would not have been achieved without a lot of the tacit knowledge that has come from the local communities, particularly in reaching the last mile of polio. Most of the solutions have actually come from the local community, and it has involved stakeholders outside of the traditional health system. So we've had to work across divide. We've had to include other kind of stakeholders at the community level. So for instance, religious organizations have played very critical roles. Similarly, health systems that are linked to those religious organizations have played very critical roles in some of the communities. So, and I think they will continue to play such significant role for other pandemic control as well. Over, Yodi.
Thank you, Kunle. Okay, now we have two more questions coming up in the Q&A. The first one is, what is the vital capacity required for a lab to be eligible to serve as a good surveillance lab? I think Dr. Hariadi will be best positioned to address this one first. Pak Hariadi, mengenai lab untuk surveillance.
Oh, maaf, saya agak kurang jelas untuk bertanya.
Persyaratan untuk lab supaya bisa disebut lab surveillance yang baik, begitu Pak Hariadi.
Oke.
Lab surveillance yang bagus itu seperti apa? Gitu,
ya, secara umum lab itu selalu terikat dalam suatu biosecurity. Dan karena lab yang memeriksa agent-agent yang berbahaya, yang maka nomor satu adalah bagaimana mencegah terjadinya kebocoran di dalam lab. Jadi syarat utama adalah biosafety dan biosecurity dari lab tadi. Dan ini menjadi salah satu syarat apakah lab tadi accredited oleh WHO. Yang kedua adalah staff yang well trained untuk melakukan pemeriksaan. Dan yang ketiga tentunya peralatan yang cukup sensitif dan spesifik untuk memeriksa. Ketiga syarat tadi memerlukan suatu syarat yang ketiga adalah specimen adequacy. Specimen adequacy ini menjadi beban ataupun tanggung jawab dari pengirim. Saya mengambil contoh untuk spesimen feces untuk polio, bahwa ada syarat-syarat yang ketat diminta, yaitu jumlahnya 8 gram, kemudian dengan suhu dipelihara antara 2 sampai 8 derajat, ya kan, dengan packing yang memadai sehingga pengiriman ke laboratorium dalam waktu maksimum 3 hari, maka syarat adekuasi tadi jumlah, kemudian kondisi dari spesimen tinja tadi, apakah kering atau bocor dan sebagainya, kemudian juga apakah terpelihara dalam suhu yang adekuat. Tanpa adanya itu, pekerja keras teman-teman di lapangan akan menjadi mubazir karena spesimen tidak bisa ditentukan apa hasilnya. Demikian juga untuk COVID. Untuk COVID, kita tergantung pada bagaimana petugas laboratorium tadi mengambil spesimen, mencolok ke dalam nasofaring kita. Ada suatu rumus sederhana. Kalau Anda merasa nyaman pada waktu diambil spesimennya, maka hati-hati. Pengambilan itu jangan-jangan salah. Pengambilan yang benar menimbulkan rasa tidak nyaman. Dan itu justru kita yakin mereka mengambil di tempat yang tepat. Jadi hati-hati. Pengambilan yang nyaman ada risiko salah ambil. Kemudian packing dan diperiksa di laboratorium. Jadi kurang lebih untuk pemeriksaan laboratorium nomor 1 adalah syarat biosecurity dan biosafety di laboratorium tadi untuk mencegah kemungkinan kebocoran lab ke lingkungan. Yang kedua, petugas yang memenuhi syarat dari segi keterampilan dan kompetensi. Dan ketiga adalah bagaimana alur spesimen masuk dari luar tadi, apakah adekuat atau tidak. Demikian Pak Jody yang bisa saya sampaikan.
Terima kasih Pak Hariadi. Jadi dicolok itu memang harusnya nggak nyaman ya Pak Hariadi. Dicolok nyaman berarti ada yang salah di situ. Alhamdulillah kemarin saya tidak nyaman dicolok-colok nanti pemeriksaannya benar. Terima kasih Pak Hariadi. Currently, there is an additional questions. How can endemic countries build capacity of health system and do effective social mobilization to reduce fatigue from repeated polio campaigns amidst internal conflict in the countries? Just to give context, the question comes from Mayera, who works in Pakistan. You can unmute yourself.
Oh yes, thank you. That's a great question, and I'm not sure there is a one answer that applies across different settings. I think each context really has to figure out how best to build those capacities within community and to sustain those capacities and continue to leverage them for other control and health system strengthening activities generally. But there are some guiding principles that helps. The guiding principle is to not think about social mobilization as something that you have to do for responding to a health problem, but actually giving ownership to community to determine resources and health issues that pertains to them. And this sounds very simplistic, but it's really a paradigm shift. That is to say that we are not telling communities what to do, but we are listening to communities in terms of what are the things that affects them and allowing them to have ownership. Of how decisions are made with regards to programs, interventions for addressing those needs. And that has really been critical, particularly in communities where the health system itself is weak. So the community health system really do play a critical role in providing services. So it's really a question of community ownership. When community people really do own programs and they see it's no longer social mobilization, it's more it's really more about a survivor for the community. It's more about the community taking the lead in making sure that the program has been sustained. But there are other things that the former health system can do. One of the things is to also recognize key personnel whose capacity has been developed over time, and folding them into the formal health system. So we have a lot of community volunteers who really they come and go, in terms of once the program ends, they go. But in some countries, for instance, in Kenya, to some extent in part of Nigeria, some of these community volunteers they've been incorporated into the formal health system. So they are still within their communities and still continue to play a role within their community, but they are recognized as a critical component within the formal health system, even as a linkage between the health facility, and the community in health production and in health promotion. And I think the issue of fatigue with repeated campaign is real. In fact, one of the studies that we have done recently showed that when we have repeated campaign, particularly in places where the health system is weak, it does not only causes fatigue for the health worker, but it also worsens the vaccine hesitancy among community members, because you keep coming. They say, why are you coming? You've been coming for the last 10 years. What are you still looking for? And one of the solutions that research have shown helps in addressing those fatigue is really understanding motivation of the community health workers, understanding their incentive regime, and being able to respond to those incentive regime appropriately. Sometimes it's not all about salary. It's not about money. It might be about recognition. It might be about listening, giving them, involving them in design of the program, in implementation of the program, and so on and so forth. So it's really around unpacking the incentive regime for the community of worker and for people who work at the community level, and being able to respond to those incentives as appropriately. But again, the solutions is really going to be context-based because community are so unique from certain to certain. So indeed, some of the solutions are going to be context-based, but there are general principles that applies as I've tried to outline.
Thank you, Kunle. So I think we've covered all of the questions in the Q&A, but we still have a remaining 5 minutes. So I'm just going to check if there's still other questions from the audience in the last 5 minutes. If not, I'm going to ask a final questions for all the panelists. Kunle, in your presentation, you alluded to the frameworks from WHO, which actually came up to some of the works which have been done in the G20, which we led as presidency of G20 in Indonesia. And in next 10 days from now, 22nd of August, we will be back in Bali for another G20 meeting. And the theme of the G20 is to transform the global health architecture. And so it would be great to hear from all of you, if you are here in Bali with the G20, with the senior officials from the Ministries of Health, what would be one thing that you would like to see to be incorporated as a recommendation for the strengthening of the global health architecture to prevent and respond for a future pandemic? So just one or two things that you would like to see there. Anybody would like to start, feel free.
Yeah, I can start, Yodi.
Yes, please.
Yeah. Thanks for bringing that up. It's really something that we have also been thinking a lot about, and it's really hard to say one thing, right? Because there are many things that are quite relevant. I think the issue of financing is really going to be critical. The issue of sustainable financing, I think, is still going to be critical. I think being able to kind of carve a pathway for sustainably financing health emergency, it's going to be key for the success of all of the other activities that will be proposed under that framework. And it will require countries to make renewed commitments. It will require communities to also make commitments, and so on and so forth. If I may add one more thing, which is really still around the resources, not just the financing, is also around maybe we think, shifting the way we think about emergencies and not think about them as emergency, but thinking about systems that respond to emergencies. So what that means is that rather than having, so we have capacity, we build capacity within our systems, and those capacities are always going to be there, whether or not there are emergencies. And those capacities might be teams or some of the operating centers that I had mentioned at different levels, global, national, global, regional, national, subnational levels. And communicating across these levels, I think, is going to be key. There's a lot of other things, but I think if I would choose two, I would take those two.
Thank you, Kunle. So the sustainable capacity, which is really critical, and the sustainable financing, sorry, and the first one. And the next one was about the capacity which is always on, not just for emergency, but a system which is always on throughout at the multiple level. Thank you, Dr. Alonge. Dr. Chako, your thoughts on what would be your key recommendation for G20?
It's this. Dr. Olakunle had taken one of my.
It's okay. You can reinforce.
Yes, I can reinforce that it is increased health allocation. I mean, post-COVID has taught all the countries in the world how important it is to prepare in advance and for future emergencies, as well as to addressing the health system issues. And so increased health allocation for Indonesia, and that can be a key recommendation. And if I may add one more thing, is that local manufacturing capacity of vaccines and other products in Indonesia, maybe Indonesia can strive to become one of the lead manufacturers in the region. I mean, that may be a big thing for Indonesia to promote during this time. I know that biopharma is one among the best in the region for local production, and then they can also try to become a good supplier to other countries in the region, like India is doing and other countries are doing also. Yeah, over. That's from me. Thank you.
Thank you, Dr. Chako. So again, reinforcing about the health allocations and then about the local capacity for manufacturing. Oke, Pak Hariadi.
Ya, terima kasih Pak Yodi. Pertama, saya ingin menggarisbawahi bahwa persepsi ataupun cara pandang terhadap fungsi surveillance itu yang harus diubah. Di banyak tempat, surveillance itu dianggap sebagai supporting komponen level 2. Saya melihat dalam suatu bangunan, surveillance adalah fondasi atau fondasi dari suatu big building. Tanpa fondasi, bangunan yang besar tadi akan rapuh. Sehingga saya setuju dengan Dr. Olakunle dan Dr. Stephen tadi, alokasi sumber daya untuk memperkuat surveillance itu harus merupakan kebijakan, bukan hanya faktor pendukung. Manpower, capacity building, sistem maintenance dan monitoring. WHO berinisiasi melalui International Health Regulation Monitoring and Evaluation Tools. Saya kira ini menjadi suatu perangkat yang perlu dipertimbangkan secara generik, bahwa setiap sistem itu harus on regular basis dimonitor dan di-adjust dengan kebutuhan pada saat itu. Karena surveillance sesuai dengan perkembangan penyakit, maka membutuhkan komponen-komponen tambahan. 20 tahun yang lalu kita hanya tergantung pada clinical symptom. Sekarang kita sangat membutuhkan dukungan laboratorium. Laboratorium sebagai komponen surveillance itu sesuatu yang mutlak sekarang. Persoalannya adalah jarak antara lapangan dengan laboratorium harus diperdekat. Mekanisme pengiriman spesimen dan peralatan harus lebih dekat. Kedua, kecepatan akan mengambil tindakan sangat tergantung pada informasi yang ada di laboratorium. World Genomic memberi pelajaran pada kita bahwa ternyata hasilnya positif dan negatif saja tidak cukup. Artinya teknologi di laboratorium akan membutuhkan akan dibutuhkan oleh komponen surveillance di dalam melihat peta masalah serta faktor risiko yang ada. Jadi artinya surveillance harus menjadi pilar utama di dalam health system dan perlu di-maintain, perlu selalu dikembangkan sesuai dengan dukungan teknologi yang ada. Terima kasih Pak Jody.
Terima kasih Dr. Hariadi. Jadi kembali ke surveillance ya, sebagai pilar utama dan itu harus disupport dengan alokasi resource sumber daya yang memadai. Okay, so thank you to our three experts who have already shared their insights with us and have also at the end I gave also some recommendation to the G20. Now we're going to move to the final section. Kita akan masuk pada bagian yang terakhir, Ibu Bapak. Tadi kita sudah mendengarkan bersama-sama sampai pada saat ini bagaimana kendala-kendala dalam masa pandemi ini terkait surveillance maupun vaksinasi, kemudian pembelajaran apa saja dari polio yang bisa kita ambil untuk bisa memperbaiki ke depan. Nah, sekarang kita akan mencoba untuk melihat ke depan, forward ya, ke depan apa yang bisa kita lakukan bersama-sama. Dan di sini sudah bersama kita Dr. Riris Andono Ahmad, Dr. Doni. Beliau adalah Direktur dari Pusat Kedokteran Tropis, FKKMK UGM, sekaligus juga Kepala Prodi S2 untuk Kedokteran Tropis dan juga menjadi koordinator dan menjadi fasilitator untuk WHO TDA Regional Training Center yang berbasis juga di Pusat Kedokteran Tropis FKKMK UGM. Dr. Doni akan berbagi pada kita pandangan pemikiran ke depannya sebaiknya bagaimana way forward-nya. Silakan Dr. Doni.
Terima kasih Pak Yodi. Sebenarnya saya justru ingin juga mengundang nanti Pak Hariadi, Dr. Stephen dan Kunle untuk ini sesi lebih pada bagaimana kita bisa menerapkan apa yang kita diskusikan itu ke apa yang perlu Indonesia lakukan ke depan secara praktis. Kalau boleh saya share screen sebentar, kita tahu bahwa saat ini kalau kita ingin menjadikan pembelajaran ini sebagai pembelajaran untuk persiapan menghadapi pandemi ke depan. Karena tadi Pak Yodi sudah mengatakan bahwa pandemi ini bukan yang terakhir dan para ahli sudah mengatakan bahwa itu hanya tinggal bukan apakah akan terjadi tetapi kapan akan terjadi. Dan selama pandemi ini kita tahu sudah ada 2 kali. Pertama kasus hepatitis yang unknown, kemudian barusan beberapa minggu yang lalu kita WHO menetapkan monkeypox sebagai public health emergency secara global. Dan jadi bisa saja itu akan membuat kita harus lebih waspada dari waktu ke waktu. Nah, menyimak pembicaraan tadi sebenarnya ini rangkuman saya sedikit bahwa komponen untuk public health response untuk pandemi itu ada beberapa. Yang ujung tombaknya itu kan adalah bagaimana kita punya surveillance dan early detection yang kuat, yang itu harus bisa dari waktu ke waktu itu vigilant seperti Pak Hariadi sampaikan, dan kita butuh investment yang sangat besar di situ. Kemudian juga setelah itu harus ada diagnosis dan case management yang kuat. Dan pada akhirnya cara kita bisa menghentikan pandemi terutama ketika kita punya vaksinasi dan bagaimana kita bisa mengimplementasikan membuat coverage vaksinasi itu menjadi sesuatu yang bisa menyebabkan terjadinya herd immunity atau bagaimana kita bisa menyebabkan penularan terhenti di populasi. Dan untuk bisa melakukan semua itu, kita butuh health system yang sangat resilient. Tadi sudah banyak dilakukan, didiskusikan. Sir Jeremy Farrar, Direktur Wellcome Trust juga mengatakan di dalam bukunya bahwa untuk merespon pandemi ke depan itu kita perlu ada transformasi sistem kesehatan. Investmentnya harus banyak di situ. Dan pada akhirnya itu tidak bisa kita lakukan juga tanpa dukungan dan support dan mobilisasi baik pada stakeholder maupun community. Pembelajaran dari polio, bagaimana vaksinasi bisa tercapai, bagaimana community surveillance itu bisa berhasil, itu butuh dukungan stakeholder dan community untuk itu terlaksana dengan baik, cakupannya tinggi dan sebagainya. Untuk bisa membuat kampanye yang bagus juga demikian. Nah, ada satu artikel di BMJ yang mengatakan bahwa ketika pandemi ini terjadi, pembelajarannya untuk negara-negara dengan respon yang baik itu punya 4 pilar terkait dengan partner, bagaimana melakukan koordinasi, apa saja yang harus dikembangkan, dan juga kemudian apa saja yang harus di-strengthenkan. Saya rasa ini juga bisa menjadi pembelajaran bagi Indonesia, bagaimana prior experiences itu dengan partner, bagaimana melakukan koordinasi dan sebagainya itu bisa jadikan pembelajaran, bagaimana apa saja sih hal yang perlu dikembangkan, yang mungkin sebelumnya belum ada, misalnya investment yang lebih besar di public health, teknologi yang baru, dan sebagainya. Tapi juga yang menjadi salah satu hal yang penting adalah strengthening pada surveillance system, bagaimana kita bisa membuat masyarakat, stakeholder itu percaya pada scientific evidence, itu sebuah dialog yang luar biasa harus dilakukan terus-menerus dan sebagainya. Nah, bagaimana ini perlu kita bisa jadikan sebuah blueprint agar Indonesia punya sistem kesiapan respon pandemi ke depan. Dan sebenarnya kita saat ini dalam periode di mana kita punya kesempatan yang bagus, karena Indonesia saat ini dengan adanya pandemi ini sebuah blessing in disguise. Kita kemudian membuat health system respon. Pak Menteri sangat begitu inginnya atau kemudian sangat begitu kuatnya dengan Pak Presiden juga bagaimana pengalaman di pandemi ini itu bisa membuat sistem kesehatan di Indonesia itu menjadi lebih kuat dan resilience ke depan. Nah, mungkin ini kita selama ini masih berjalan reformasi kesehatannya, masih ada kesempatan bagi kita untuk memberikan masukan pada sistem kesehatan berbagai macam respon ke sistem kesehatan itu, sehingga saya sebenarnya pengen instead daripada saya mensintesi way forward, saya sebenarnya ingin mengundang juga sedikit masukan, terutama dari panelis, terutama Pak Hariadi, Dr. Stephen, dan mungkin nanti ada komentar dari Kunle, apa sih dalam waktu yang masih ada waktu ini, kira-kira apa hal-hal yang perlu Indonesia lakukan dalam hal yang tadi disebutkan, juga pengalaman Dr. Jackson, Pak Hariadi, agar kita bisa memberikan kontribusi dalam transformasi sistem kesehatan tersebut. Dan juga mungkin dari pengalaman Dr. Jackson dan Pak Hariadi, apa yang masih missing tadi dalam matrik negara-negara yang bisa baik itu ada beberapa hal yang masih missing dan di-develop dan apa yang di-strengthen. Tadi sudah Pak Hariadi banyak menjelaskan tentang strengthening surveillance system. Tetapi adakah hal yang lain yang mungkin bisa kita sampaikan kepada pengambil kebijakan agar transformasi sistem kesehatan itu juga tidak missing, ada bagian-bagian yang missing untuk ditambahkan atau kemudian perlu di-strengthen lagi. Ini mohon maaf, ini saya dari moderator dalam moderator, tapi mungkin Pak Yodi bisa juga membuat ini menjadi memoderasi pertanyaan ini.
Okay. Baik, terima kasih Pak Doni. Okay, so to the panelists, we have additional question from Pak Doni, which perhaps you can address briefly regarding what are the immediate actions that we need to strengthen pandemic preparedness, and then whether there are still some missing and things that we need to better in terms of the investment. So if anybody wants to weigh in on top of what we've already discussed for the G20.
Ya.
Who would like to start? Dr. Hariadi mungkin akan mulai.
Terima kasih Pak Jody, terima kasih Pak Doni. Menarik sekali. Saya kebetulan beberapa waktu terlibat dalam diskusi ini. Jadi kalau kita bicara pandemi, maka itu ada dua komponen yang harus kita perhatikan adalah internal system. Jadi sistem surveillance atau health system di negara, katakanlah di Indonesia. Namun karena pandemi ini adalah adanya interaksi ancaman dari negara lain, maka bagaimana health system yang ada di negara lain tadi? Jadi interoperability dan interfacing antar dua negara itu menjadi salah satu komponen. Hal ini menjadi penting sekali karena mobilitas penduduk itu sekarang sudah tidak bicara antar provinsi lagi, tapi sudah antar negara. Pengalaman kita, bagaimana kita kemasukan berbagai agent tadi, lebih banyak disebabkan karena adanya pendatang atau orang Indonesia yang pulang dari negara lain dengan membawa penyakit tadi. Artinya, kembali, bagaimana apakah ada mekanisme yang bisa disepakati antar negara, entah infected country dengan negara lain, supaya komunikasi ini bisa dibangun. Yang saya ketahui berdasarkan International Health Regulation, masing-masing negara telah diwajibkan memiliki suatu sistem dan ada IHR focal point yang terkait dengan WHO. Tapi kita ambil contoh Indonesia dengan Malaysia, itu berada pada dua region yang berbeda. Sehingga WHO focal point-nya pun antara Shero dan Webro, dua. Padahal kita tergabung dalam satu wadah ASEAN. Nah, Pak Menteri mengendaki adanya suatu interoperability mechanism sehingga cross-border notification tadi betul-betul menjadi suatu hal yang sangat mudah. Untuk itu perlu ada kesamaan sistem yang bisa disepakati. Faktor yang kedua adalah tadi Pak Olakunle tadi mengatakan resource allocation. Kesenjangan ketersediaan resource tadi akan menjadi kendala terbesar. Untuk Indonesia, dengan adanya otonomi daerah, maka kegiatan-kegiatan yang didelegasikan kepada kabupaten, sering hasilnya tidak seperti yang diharapkan oleh pemerintah pusat. Nah, less allocation ini menjadi kendala dari pelaksanaan. Policy-nya sudah oke. We have the right things to do. But we don't have that doing the things right at the peripheral level. Dan ini ada beberapa contoh di mana kasus COVID sudah ditemukan, tapi tidak ada biaya operasional untuk investigasi kontak. Terima kasih.
Terima kasih, Dr. Hariadi. Kunle, would you like to weigh in?
Yeah. Thanks for raising that question, Doni. I mean, I'm not going to repeat what has been said already. So I think all of the things that have been said applies. But I would just like to make a plug for building capacity, particularly given the unique context of Indonesia, a country of 17,000 islands. You need capacity in each of those communities. But when I say capacity, you need capacity to mobilize, you need capacity to do epidemiology, you need capacity to do laboratory work, and you need capacity in implementation science to implement effectively. So I think being intentional in building strategic capacity in a decentralized fashion, I think might be important for Indonesia.
Thank you, Kunle. So ensuring strategic capacity. Dr. Chako, please.
Yeah, thank you, Dr. Riris, for raising this question. So I think we are, some of this will be a repetition, but I think it is important to reiterate and highlight the community component of it, what Dr. Kunle had mentioned, that if you take the lessons learned from COVID or even the previous ones, wherever the community part is missing, that is what is going to take us more and more time to address the situation. So when we talk about, in your presentation, you had mentioned the surveillance part, diagnosis and vaccination, resilience, health system, stakeholder and community engagement and support. But everywhere, I think the action happens at the community level, and mostly, I mean, and if we miss that component, we miss out hugely in terms of coverage and in terms of early detection, in terms of any public health outcomes. Yeah, so that it needs to be reiterated. That should be the central point. And it can be an informer, yeah, I mean, from the community can be a vital component and for the surveillance system. Doesn't need to be a highly sophisticated surveillance system, but reaching out to the community is so important. And then Hariadi's mention about the resource allocation, it should be equitably distributed. I mean, as a upper middle income country, Indonesia is allocating sufficient resources, looks like, I mean, but maybe when we look at the Puskesmas level, sometimes it doesn't reach, in some areas are more than sufficient and some areas maybe not sufficient. So whenever for a pandemic preparedness, these are the components we need to keep in mind. The resource allocation at the community level, and then the involvement, engagement of community, and then the vigilance and the capacity at the various sectors, what Kunle also mentioned, that it is such a country with so much of logistical challenges, which the adequate capacity at various levels are required. So thank you over from my side.
Thank you, Dr. Chako. Ya. Pak Doni, ada yang mau ditambahkan?
Ya, terima kasih. Saya rasa ini menjadi sangat relevan karena salah satu output dari acara ini kita akan melakukan advokasi juga kepada pemerintah melalui mungkin policy brief, policy dokumen agar ini bisa kita kontribusikan ke dalam rangka masukan untuk reformasi sistem kesehatan kita. Dan saya rasa ini memang bagian yang banyak juga disebutkan di dalam berbagai macam dokumen kebijakan global, bagaimana kita membuat sistem kesehatan yang lebih resilient, dan untuk spesifik Indonesia yang memang desentralisasinya sangat kuat, bagaimana berbagai macam kebutuhan ini, hal investasi ini bisa di tailor-made agar sesuai dengan situasi desentralisasi menjadi sangat penting. Terima kasih Pak Yodi, terima kasih kepada semua panelis. Saya kembalikan kepada Pak Yodi.
Terima kasih Pak Doni, terima kasih Ibu Bapak semua. Ya, karena waktunya sudah hampir habis ya, meskipun sebenarnya saya yakin masih banyak yang perlu kita diskusikan. Mungkin sedikit menggarisbawahi beberapa hal. Yang pertama disampaikan oleh Pak Doni tadi. Jadi memang untuk kedepannya seperti memang masih banyak PR ya Pak Doni yang perlu kita advokasikan, dan sebenarnya ini tidak hanya reformasi tapi transformasi bahkan karena banyak hal yang sangat fundamental yang perlu kita upayakan di sini. Ini perubahan-perubahan yang sangat besar. Bahkan bisa dikatakan istilahnya transform or perish. If you don't transform, you will perish. Karena memang hal-hal yang diperlukan untuk menghadapi krisis berikutnya itu akan sangat-sangat fundamental, perubahan yang perlu kita lakukan. Dan itu tidak bisa hanya rely on WHO ataupun Kementerian Kesehatan begitu, tapi adalah PR kita bersama, baik itu WHO, baik itu Kementerian Kesehatan, baik itu akademisi, civil society, masyarakat dan sebagainya. Jadi ini PR kita bersama Bapak Ibu sekalian, dan saya kira itu adalah take home message untuk webinar kita kali ini, bahwa masih banyak PR dan ini akan menjadi PR kita bersama untuk menghadapi pandemi-pandemi berikutnya. Saya kira itu. So thank you again for all our expert, Dr. Hariadi, Dr. Chako, Dr. Alonge, Dr. Doni. Thank you for sharing your insight, your expertise, and I return it back to the master of ceremony. Please give an applause first to our experts. Virtual applause. Thank
Thank
you.
you, everybody.
Thank you.
Baik, terima kasih banyak
Yeah.
Pak Yodi, terima kasih banyak kepada seluruh pembicara
Thank you,
pada
Thank you.
kesempatan kali ini. Tak lupa kami juga ingin mengucapkan terima kasih kepada Anda Bapak Ibu peserta yang sudah turut hadir dalam acara kali ini. Tak lupa kami ingin kembali mengingatkan terkait dengan e-certificate untuk Bapak Ibu bisa mengisi link presensi yang tersedia di kolom chat. Kami tunggu hingga nanti malam pukul 23:59 waktu Indonesia bagian Barat. Dan e-certificate akan bisa diakses paling lama 2 minggu setelah acara ini berlangsung. Dan jika belum, silakan untuk mengkontak centertropmed.fkkmk@ugm.ac.id. Sekali lagi nanti Bapak Ibu jika belum mendapatkan e-certificate bisa mengirimkan email ke centertropmed.fkkmk@ugm.ac.id. Dan Bapak Ibu bisa nantikan acara menarik lainnya dari Pusat Kedokteran Tropis Universitas Gadjah Mada. Update-nya bisa Bapak Ibu saksikan di berbagai kanal sosial media Pusat Kedokteran Tropis UGM. Ada di YouTube, Twitter, Instagram, Facebook, LinkedIn, dan juga websitenya di centertropmed-ugm.org. Baik, atas nama panitia yang bertugas, saya Rima pamit undur diri. Terima kasih. Matur nuwun, matur suksme. Wassalamualaikum warahmatullahi wabarakatuh dan sampai jumpa.
Terima kasih.
Terima kasih. Thank you everyone.
Thank you everyone.
Terima kasih.
Thank you Kunle, Pak Hariadi.
Thank you everyone. Bye-bye.
Thank you, Anna. Dr. Jackson.
Doni, are we?
Yes, we move to the next room.
Okay. So I'll just send the link.